Hello everyone. This video will go over the results of the rigorous evaluation study that was conducted in Rhode Island under the CDC Community Health Worker Initiative, also referred to as a CCR grant. In 2023, between the months of February and June, the rigorous evaluation compared the impact of Road to Equity, or R2E, community health workers or CHWs, with non-R2E CHWs. Insights were gathered from focus groups, interviews, an activity survey, and functionality matrix. CHWs from 6 R2E teams working in health equity zones or HEZ organizations received support from multi-disciplinary teams, coaches, technical support, RIDOH CHW Program Staff, and the Pathways to Population Health model. On the non-R2E side of this comparison study, CHWs from 5 HEZs received support from the Rhode Island Department of Health, or RIDOH, CHW program through office hours, evaluation assistance, and technical assistance. To understand the roles of CHWs in R2E teams and CHWs in non-R2E teams, we utilized focus groups and an activity survey, both administered to CHWs and HEZ leads. Through all combined activities, 12 CHWs were studied in total, with representation from all R2E teams and HEZs. In both R2E and non-R2E teams, we found that CHWs involved in community engagement in addressing social determinants of health, health promotion and education, and care coordination. Non-R2E teams were found to exhibit a strong commitment to engaging directly with communities, focusing on building trust and enhancing access to health and social services. Similarly, we found that R2E teams leveraged the unique experiences of CHWs to better understand community needs and forge stronger connections between clinical services and the community. Moreover, while non-R2E teams prioritize culturally appropriate health education and capacity building within communities, R2E teams are involved in broader health initiatives that likely include educational components. Additionally, the integration of care coordination into healthcare pathways and systems was found to be more explicit in R2E teams when compared to the indirect involvement seen in non-R2E teams. In all these activities, this rigorous evaluation study found no significant differences in frequency of activities between R2E versus non-R2E teams. Variation was found between HEZ organizations, suggesting greater impact from organizational factors, not from R2E or Road to Equity trainings. We also found that both R2E and non-R2E teams cited networking as beneficial for resource sharing. CHW said that they gained support through CHW networks, but feel like these networks need to be expanded and structured so that CHWs can collaborate even more. As a next step, CHW said that they want to build tables or create convenings where CHWs can gather to share resources and collaborate across HEZs. To understand the impact of R2E and non-R2E CHWs, we drew upon qualitative insights from interviews and focus groups with CHWs and HEZ organizational leaders. In R2E and non-R2E teams, we found that there is an emphasis on direct community engagement and support, including activities such as food services and outreach. Both parties actively establish and operate food pantries, demonstrating their commitment to addressing community food security. CHWs on both sides play vital roles in advocating for community health and addressing specific health concerns. They utilize various skills from trainings to provide specialized care and guidance to diverse populations. Moreover, CHWs build trust within their communities by fostering connections and providing culturally relevant services. In R2E teams, CHWs serve as liaisons between clinical teams and community organizations, facilitating improved clinical community linkages and ensuring timely access to healthcare. As a result of their efforts, tangible improvements in health outcomes have been observed, such as reductions in chronic illness and improvements in chronic disease management. Despite similarities, differences exist. As previously noted, CHWs from Road to Equity teams were compared to non-R2E CHWs. The Rhode Island Department of Health CHW program received special funding from CDC under Component B of the CCR grant to help support the second group of CHWs. By comparison, we found that CHWs working under this B side of the grant emphasized the expansion of program activities due to increased funding, direct initiatives, and the formation of partnerships with other services. This has allowed for a strong and growing impact on the community. By comparison, CHWs who were studied under the Component C side of the grant, namely the Road to Equity or R2E initiative, had prioritized staff training and immediate outcomes such as reduced ER visits, improved health outcomes, and comprehensive family support. Next, we drew upon qualitative and quantitative insights from interviews, focus groups, and a functionality matrix to assess CHW support effectiveness. In terms of leadership, we found that Road to Equity CHWs show influential engagement with leadership and policymaking processes, whereas non-R2E CHWs show more direct autonomy and leadership within their immediate work environment. Both R2E and non-R2E teams felt valued and supported by their leadership within an environment that was conducive to professional growth. Early data from the functionality matrix suggests slightly better effectiveness scores for grant component C teams, but more information and context is needed to be sure. As next steps, we suggest each team create individual improvement plans to understand the roles, responsibilities, and opportunities of CHWs within the team. Additionally, health equity zones, or HEZ organizational teams, can build stronger collective collaborations to coordinate efforts and leverage collective resources, expertise, and networks to address complex community needs more effectively. In addition to CHWs and organization leaders, focus groups were also conducted with people with lived experience, or PLEs, in Road to Equity teams. Focus group results showed that PLEs are highly dedicated to their work, understanding the value of their lived experience. Their lived experience helps address community issues, specifically housing, health, and food insecurity. Despite commitment, PLEs face difficulties in communication, inequitable interactions, and lack of implementation of the ideas, impacting their sense of value and inclusion. As we close here, it's also important to note how this study had identified challenges faced by people with lived experiences. We suggest prioritizing communication between community health workers and people with lived experiences. This would require adequate time for both parties to interact and collaborate during meetings, prioritizing attendance at meetings with leadership, and creating routes of accountability that track CHW's engagement of PLEs, such as monthly tracking of CHW and PLE meetings. Thank you for your time. If you have any questions or requests for evaluation technical assistance, you may reach our team at the emails shown on screen here.